Renal failure and haemoptysis. Scenario: a 66-year-old man presents with a 5-week history of malaise, myalgia, arthralgia, and increasing breathlessness. In the week leading up to admission he begins to cough up blood and his GP performs blood tests that reveal creatinine 580 micromoles/L and hemoglobin 8.4 g/dL. He immediately goes to the patient's house to reassess him, notices a purpuric rash and organizes emergency admission. Introduction. This man almost certainly has a pulmonary renal syndrome, which is defined as a combination of diffuse pulmonary hemorrhage and glomerulonephritis. If not treated urgently, this is usually fatal, and despite aggressive treatment, mortality remains in the region of 25 to 50%. Pulmonary renal syndromes are usually caused by immunologically mediated diseases, with most cases due to vasculitis, often positive for antineutrophil cytoplasmic antibodies, ANCA, such as microscopic polyangiitis or Wegener's granulomatosis. Antiglomerular basement membrane, GBM, disease, Goodpasture's disease. Systemic lupus erythematosus, SLE. Other causes of acute renal failure can be complicated by pulmonary edema, infection, or an increase in capillary permeability that may not be easy to distinguish from pulmonary hemorrhage. Patients with severe pneumonia can develop acute renal failure as part of a sepsis syndrome, and these also need to be distinguished, in particular because their treatment is radically different. NB. Acute renal failure with blood and protein in the urine plus haemoptysis indicates a pulmonary renal syndrome until proved otherwise. This is a medical emergency. History of the presenting problem. A detailed medical history is crucial. The presence of systemic symptoms and abnormalities in other organ systems may indicate a systemic vasculitis, SLE, or an alternative diagnosis. The initial symptoms of many conditions, ranging from pneumonia to vasculitis, are relatively nonspecific and include lethargy, fever, weight loss, arthralgia, and a nonspecific feeling of being unwell. Probe for clues to the following diagnoses. Vasculitis, skin rash, abdominal pain, and focal numbness or weakness. Mononeuritis, this can be precipitated by some drugs, e.g. penicillamine, hydralazine. Wegener's granulomatosis, sinus and upper respiratory tract symptoms, which may have been investigated in the past, also symptoms of generalized vasculitis. Goodpasture's disease, can be triggered by inhaled hydrocarbons. Pulmonary hemorrhage occurs almost exclusively in smokers. Churg-Strauss syndrome, asthma and nasal polyps, also symptoms of generalized vasculitis. SLE, arthralgia, alopecia, and pleurisy, commonly in those of African, Asian, or Afro-Caribbean ethnicity. Pneumonia or other severe sepsis, any obvious symptoms suggesting infection, e.g. rigors, or dysuria. Always ask about travel history. Examination. As always, the first priority is to make an overall assessment of the patient. Is he well, ill, very ill, or nearly dead? The description given here suggests that this man might be very ill or worse. If he is, call for help from the intensive care unit immediately. In addition to features indicative of the severity of his illness, note the following. Signs of active vasculitis: palpable purpura, Fig 13, splinter hemorrhages, uveitis, mononeuritis multiplex and Roth's spots. A collapsed nasal bridge is very suggestive of Wegener's granulomatosis. Signs of SLE: alopecia, butterfly rash, arthritis, and vasculitic skin lesions. Chest: there may be few abnormalities despite significant pulmonary hemorrhage. Investigations. Blood and other routine tests. To assess severity and monitor for complications and progress, FBC, clotting screen, electrolytes, and creatinine, liver/bone function, C-reactive protein, erythrocyte sedimentation rate and ECG. To make a diagnosis of vasculitis/autoimmune disease, ANCA, anti-GBM antibodies, anti-nuclear antibodies, anti-double-stranded DNA antibodies and complement, C3 and C4. To make a diagnosis of an infection-related syndrome, blood cultures and anti-streptolysin antibody titers. To support treatment, blood cross-match. Lung investigations. CXR should clearly be a first-line investigation in this case, looking for appearances suggesting diffuse alveolar hemorrhage, Fig 14. Consider the following, depending on the fitness of the patient and clinical suspicion. Lung function tests, if the patient is well enough, which he may not be, looking for elevated KCO indicating pulmonary hemorrhage. CT scan of the chest, this may show appearances characteristic of alveolar bleeding. It is also good for demonstrating other pathology, e.g. pneumonia. Bronchoscopy and bronchoalveolar lavage, if infection is strongly suspected. Renal investigations. Urine dipstick testing for proteinuria and hematuria, and urine microscopy for red cell casts are urgently required because they can establish the diagnosis of a renal inflammatory lesion. Urinary tract ultrasonography will be needed to demonstrate the presence of two normal-sized, and unobstructed, kidneys prior to renal biopsy, which will almost certainly be required to establish a definitive diagnosis of the particular type of pulmonary renal syndrome. Key things to look for on the renal biopsy include the following. Vasculitis, glomeruli that contain crescents, cells and material within Bowman's space and outside the glomerular capillary tuft, which they may compress, hence crescentic glomerulonephritis, and areas of necrosis, pink amorphous material within the glomerular tuft on a standard hematoxylin/eosin stain, hence necrotizing glomerulonephritis, but no immunoglobulins or complement in the glomeruli, hence pauci-immune glomerulonephritis. Not all glomeruli may be affected, hence focal glomerulonephritis, and within a glomerulus not all parts may be involved, hence segmental glomerulonephritis, Fig 15. Linear IgG deposition along the capillary basement membrane, Goodpasture's disease. Deposition of immunoglobulins and complement in the glomeruli, lupus/post-streptococcal glomerulonephritis. Management. Supportive care. Patients with pulmonary hemorrhage are often very ill and require the following. Respiratory support, oxygen, high flow via reservoir bag if needed, to maintain adequate PO2 levels, saturation greater than 92%, ventilation if hypoxia does not respond to other measures. Hemostatic support, blood transfusion, if anemic, correction of clotting abnormalities. Treatment of infection, low threshold for administration of antibiotics if infection is suspected. Renal replacement therapy, hemodialysis or hemofiltration if appropriate, and without heparin if possible. Specific treatments. If pulmonary hemorrhage is secondary to vasculitis Goodpasture's disease or SLE, management should clearly be directed by an appropriate specialist, but the most commonly used initial treatment is a combination of the following. Steroids, usually initiated as intravenous methylprednisolone and then oral prednisolone. Immunosuppressant, cyclophosphamide. Plasma exchange/plasmapheresis, this is definitely indicated for the treatment of Goodpasture's disease with pulmonary hemorrhage, where the antibody is directly pathogenic. It is also used in pulmonary hemorrhage due to ANCA-associated vasculitis and SLE in some centers or cases. A range of other immunosuppressants have been used with some success in individual cases. Further comments. Anti-GBM disease, good pastures is almost always a one-hit condition and does not relapse. In contrast, ANCA-positive vasculitis and SLE have a high incidence of relapse, and treatment is usually maintained for years. Repeated episodes of pulmonary hemorrhage can cause pulmonary fibrosis.